It is very much my pleasure to introduce to you our ground round speaker this morning, a colleague, Dr. Susan Berry, who is a professor in the departments of pediatrics and also genetics, cell development, and biology. Sue is really well known in many circles as being one of the absolutely top medical geneticists in the country. And for those of us who deal with are on the phone a lot from our laboratories, helping people to determine what tests they should order for a particular patient, now when there's confronted perhaps in clinic with a patient who has some minor anomalies or a constellation of odd clinical findings or more severe congenital malformations, and they're trying to determine which type of NextGen sequencing they should do, whether it's a short panel, a whole exome, or maybe a whole genome. Many people would say that the first step in that testing algorithm should be a visit to Dr. Sue Berry, who would probably make the clinical diagnosis, and then you'd be down to one test, one gene sequencing to confirm her diagnosis. Sue is, in addition, extremely well known in the area of inherited metabolic disorders and has had major impact in the field of newborn screening. Just to mention a few of the many pages of committees that she attends where her influence is significant. She is the chair of the Clinical Integration Workgroup for the Newborn Screening Translational Research Network. She is a member of the Board of Directors for the Society of Inherited Metabolic Diseases. She is the chair of the Therapeutic Committee for the American College of Genetics and Genomics. She is a member of the Long-Term Follow-Up and Treatment Subcommittee for the U.S. Department of Health and Human Services Secretary Advisory Committee on Heritable Disorders. And that's just a few of the several pages that are here that I am reading. Sue is a terrific colleague. She is someone who really generously shares her expertise with all of our fellows and also with residents and medical students. And she is recognized not just by the colleges that are responsible, like the American College of Medical Genetics and Genomics, and she's also you right now are the chair of the Minnesota Pediatrics Academy of...
I'm the past president of the Minnesota chapter.
Okay, thank you, the Minnesota chapter. But also if there hasn't been any kind of mess up by Price Waterhouse, she has been continually named as a top doctor since 2007 by Minnesota Monthly and Minneapolis St. Paul magazine, and has been named one of the 100 most influential healthcare leaders in Minnesota. So with that, I am extremely happy that she is here to share her expertise with us, particularly on newborn screening. We're at a very interesting time with kind of traditional screening and coming into a molecular world. So Sue, with that, thank you.
It's great to see so many familiar faces and friends here, and I appreciate your coming today because this is not the best day to drive. So, Betsy has told you of my fondness for newborn screening, and it's almost an obsession, is the way I can say it. Sort of I'm always thinking about it and what's going to happen next and how we can make it work better. I see John here. He knows that we've been working on making newborn screening better for many, many years. And so with that in mind, I'm going to tell you a little bit about the newborn screening process because although you're laboratorians and know lots about lab stuff, I don't know that you always know what happens in the broader community about something as specific as this program. So if you're already a big newborn screening aficionado, bear with me and we'll just go ahead. All right, so where's it been and where's it going? I wish I had a crystal ball. All right, I'll skip that. Here's kind of how I'm going to do this, which is I'm going to talk a little bit about sort of the general concept of newborn screening, its history and principles. I'm going to talk about newborn screening and the process that occurs with regard to not so much how it's done, but how it is increased in its scope. And then I'm going to talk a little bit about my own research activity, which is primarily in the area of long-term follow-up. Because I was trying to limit myself, I made that piece a little bit shorter, so it's not as data-rich as it probably deserves to be, but bear with it again. And then I want to talk a little bit about what's up next, because I think this is really a place where academic medical centers are going to have a tremendous impact in how newborn screening evolves. All right, so that's what it's about. That's a baby getting a blood spot collection done. The technically best way to do it is a direct application from the heel onto the paper filter. So this is the crown jewel of public health in many ways. There are many other important public health programs, but this is the one in some ways that's really been such an exemplar for the interaction of public health with clinical activity. It's a tremendously successful program that has allowed the saving of many lives. Now, the point, and we'll go into this in a little more detail, is that newborn screening programs test for disorders that aren't evident clinically. You wouldn't know the baby sitting in front of you has this disorder. It's an invisible disorder until like day 3 or 4. All right, so the majority of the tests that are done are identifying using standard analytical techniques in public health laboratories. To a large extent, this takes place in public health. Now, there are, in addition, we could go into long, hairy details about this, and I probably won't do it, about point-of-service tests, but hearing screening and screening for critical congenital heart disease are point-of-services tests whose information flow is managed at this point by mandate in public health. And so it's done in different days in different places. Sometimes the newborn screening program that does the blood spots manages that. Sometimes it's completely separate. That's beginning to point out one of the problems. It's different every place. But the point I want you to take from this is that these activities, these tests that are performed on almost every baby are done because of a public health mandate. Everybody's screened unless somebody screws up. And there's, as much as anybody can have it happen, no choice about whether a baby is screened. Babies are done, it's for the greater good. The idea is that somehow, that performing this test and finding these conditions is of such importance that it's mandated by law. And that's different than most of the tests we ever do for almost anything else. If somebody would want to do one of the things that we think would be really helpful, they don't have to do it. If a parent refuses to get blood drawn for chromosomes, I can only say, well, don't you want to know? But I can't make them do it. Whereas without some effort, it's pretty hard to get out of doing newborn screening. And ironically, most people never know it happened. I'd probably do better with that. All right, so this is the oldest population-based screening that's used widely. At this point, I'll get to how this kind of happened, but it's done in all the U.S. states, the territories, military. Many other countries also have robust newborn screening systems. But there are evolving standards for what you screen for, what's on the newborn screening panel. So we'll talk a little bit about that in more detail. Okay, so just historically, just to give you a perspective, a time course, because I think this is important. This is not something that's been learned that long. This is actually relatively short-term knowledge. PKU isn't even that well known. 1934, it seems like a long time ago, but it's not that long ago, was first described. And the first commercial product to treat PKU, people realized they could actually treat it, didn't happen until 1958. The real key for newborn screening is that Bob Guthrie, because of his knowledge of a family member who had PKU, started fooling around saying, well, I could figure out that. I could do something with that. And he came up with the bacterial inhibition assay to test for phenylalanine. With that, he was able to create a test that could be done in a higher throughput method instead of measuring phenylalanine by methodologies that were a lot less robust than even we have now. So this was a simple, easy test that could allow high throughput assessment of blood phenylalanine. And that allowed those who were dreamers at that moment to say, well, we could screen. We could do this. And what more, we've learned that if you treat PKU early, you can pretty much stop the intellectual disability that results from untreated accumulation of phenylalanine. So it was a very exciting time in the early 60s when Massachusetts initiated the first screening trial for blood spot screening for PKU. So in 2013, the CDC and all of the newborn screening programs had a big party for the 50 years of newborn screening. By 1975, 43 states were screening, but that tells you one of the problems that we will continue to struggle with, as far as I can tell. And that is that performance of newborn screening wasn't the same from state to state. So why would you screen? People will trot this set of things out, and people always, when they look at this and talk about it, they think it's talking about newborn screening, but it's not. It's talking about public health screening. And these are the so-called Wilson and Younger criteria for population-based screening of almost anything. So you have to have an important health problem, there should be a treatment, you should have a way to get people for diagnosis and treatment. You should be able to identify it at a state before it has an impact. You should have a test. The test should be something that people will do. The natural history should be known. We haven't even gotten that far yet, just so you know. You should have a policy on who you should treat. The cost should be manageable, and you have to do this on a continuous basis. And that makes it a public health concept. So this is the sort of the expectation, if you will, for population-based screening that really is the foundation for newborn blood spot screening and the public health mandate for it. I mentioned that one of the things that was a challenge with regard to newborn screenings, every state did it differently. Massachusetts developed a whole mass of bacterial inhibition assays, and they screened for all sorts of stuff, even stuff they maybe shouldn't have screened for, but they had a very broad screening panel. But most states, if they screened for very much, screened for anywhere from 2 to 5 conditions. And the two that were most common to screen for were PKU and hypothyroidism. But some states also did sickle, and some didn't. Some did galactosemia, some didn't. It was really uneven and not very deep. One of the things that happened about that time then is that technology for doing multiplex assays of profiles of metabolites emerged. And the big breakthrough in that was the development of high throughput use of tandem mass spectrometry, so that you could develop a profile of metabolites that would allow you to do diagnosis. In states that started to play with this and initiate it, they realized that they could screen for a very broad spectrum of disorders, and so some of them started doing it. And so all of a sudden you have one state that's screening for 50, 60 disorders, and another one next door that's screening for 5. This was perceived as unjust. It wasn't fair that if you were across the border you get something different. And that was highlighted tremendously in California when California began exploring implementation of MSMS, and there were 2 kids in adjoining hospitals, one undergoing the pilot, one not. So these are the so-called 2 Zachs. And Zach number 1 was in a hospital that wasn't screening, and he was born and went home, and months later was clearly found to be impacted by glutaric acidemia type 1 and devastated neurologically at about age 7 or 8 months. Zach 2 was born in a trial hospital, was identified as having GA1, and was a normal baby with treatment. And that stark comparison, I think, really hit home very materially to the newborn screening community and to the broader community that it isn't fair. So the Newborn Screening Saves Lives Act was enacted in 2007. And this is an amendment to the Public Health Service Act. It expanded what was then called the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children. It's often referred to, and even now, even though it has slightly different initials, as SACHONC. not a particular euphonious, SACHONC. That law mandated a clearinghouse of information for the public that was run by Genetic Alliance. It also mandated interagency coordination for newborn screening services. The Health Services Service Administration was asked to support regional genetic collaboratives for dissemination of information and improvement of newborn screening. And those regional genetics collaborative were a unique confluence of public health professionals and clinicians, which still are active to this day. CDC was supposed to facilitate, the simple thing is to call it, facilitate quality assurance. And what that really meant was making a much more robust infrastructure for making sure that every lab that implemented newborn screening had the technical skills and materials and appropriate control materials to undertake newborn screening. And that job is expanded mightily and continues to be a very powerful element of this. And then NIH was supposed to do more research. They added the Hunter Kelly Newborn Screening Research Program and dumped some money into really advancing newborn screening research activity. This act was also reauthorized in 2014. I'll get to that. It caused some complications and consternation upon reauthorization. So what they determined was necessary as this came up is that the justice issue had become to the forefront. It wasn't fair that things were different from state to state. So the HRSA asked the American College of Medical Genetics to develop guidelines for newborn screening. What they desired and what was needed was a uniform condition panel. They also asked for model policies and procedures for state programs so that they would perform things in essentially similar ways. They wanted some minimum standards. That's to really invoke some of the CDC activities. They wanted a decision matrix for how state newborn screening programs would expand. And this is important because every state, no matter what you decide you're going to do on a federal level, each state does whatever the hell they please. That remains one of the issues in newborn screening. But we needed a national process for quality assurance and oversight. So that's what the so-called HRSA guidelines were. Those are the elements of it. But what they basically wanted to say is what needs to be on the screening panel and how we decide. So the criteria that were used when they created the uniform screening panel were modifications of the Junger and Wilson criteria. They wanted to have a treatment. They wanted to have evidence that early treatment improved outcome. That's actually pretty important because you can treat lots of things, but you may not make a bit of difference, right? So I can treat all sorts of stuff. I can use whatever, but it may not make any difference. You want to have something where somebody's asymptomatic or you can't tell that they have something wrong with them. We need a rapidly implementable, highly sensitive test. It has to be cost effective, and you have to have, it doesn't do any good to screen if you've got nobody to take care of things. This remains a problem. Also, we have a volume problem in our profession, but the infrastructure has to exist to help families and medical homes connect with specialists, and you have to have a way to confirm the disorder. You have to be able to treat it, and most importantly, you need to follow it up. Newborn screening is a process, not an event. All right, so the assumptions that they had to make for the things that had to be our primary targets for newborn screening had to be identifiable at an early phase. It couldn't just that you had a good test. Wouldn't do any good if the test needed to wait till they were 2 months old. So it has to be something that shows up pretty quickly after birth, and when it wouldn't be identifiable clinically. You have to have a good test, and you have to have the demonstrated benefits of early detection, intervention, and treatment. All right, just a reminder, because I know all of you know this, but inborn errors of metabolism are mostly disorders of catabolic enzymes. They're processing problems. They're almost all autosomal recessive until very recently. All of the disorders that were screened for, if they were genetic at all, were autosomal recessive disorders. And of course, the most severe of these present in newborns, so the sooner you catch them, the better you're going to do. And what the newborn screening process depends on is this cartoon of all that you need to know about inborn errors of metabolism, secretly. Just substitute whatever you want in that pathway, and you either get too little product, too much precursor, or you shunt to an alternative path. There's some hedges on that, but that's basically all there is. That's a secret. I don't tell anybody, because then they would know that I don't really have to know very much to do my job. All right. after much angst, wrangling, discussions, argument, many, many meetings, lots of fussing and mussing and bussing, remember that they were using primarily tandem mass spectrometry to do this. And so what really emerged was core conditions that could be, to a large extent, tested for in multiplex panels. So there are organic acid conditions. I would go through them all, but it doesn't matter because you know it when you need to know it. Fatty acid oxidation disorders, amino acid disorders, including our old friend PKU, which now is not tested for by a Guthrie method, but by tandem mass. Endocrine disorders had been evolving, so the most common newborn blood spot diagnosed disorder is congenital hypothyroidism, by far. But also congenital adrenal hyperplasia, which is basically an inborn error of metabolism also. Hemoglobinopathies were also a target and were identified as primary disorders for screening. And then biotinidase deficiency, cystic fibrosis, galactosemia, all of which kind of need individual tests. I have 2 in red here because they've been added to the original panel of 26. And I'll mention that there are 3 new disorders that have just been added. I'll come back to why and how that happens. But the takeaway from this is that almost all of these are autosomal recessive disorders diagnosed by analyte or enzymopathy testing. All right, so here's the downstream effect of identifying in multiplex panels, which is that you get what you get and then you have to decide what you share, right? So you're going to get a complete profile. So the 2 profiles that are done are an amino acid panel and an acyl carnitine profile. Those are done as the tandem MS, those two metabolite panels. And you're going to get metabolites you're going to have 2 problems. You're not going to get disease diagnoses. You're going to get metabolite profiles. So there's often a differential diagnosis for one given metabolite. My favorite one is the C5-hydroxy because there's 6 diseases you have to think about. And the one that's most common, but you have to be, all of them happen, and you have to be ready to diagnose any of them. And the other thing that happens is you get a bunch of stuff on that profile that you don't know what to do with. It's kind of like it's not like a variant of unknown significance, but you don't know what to do with those either. So you get these secondary analytes and you say, well, what do we do with them? Because they might not be conditions that are improved by treatment, but don't people deserve to know they have it if you diagnose it? They might be conditions that have that are improved if you treat them. They might not be a condition you should even diagnose because they're not really a disease. We've run into all of those problems with the so-called secondary targets because when they decided to set up now what's called the RUSP, fondly by the people who love newborn screening, they call it the RUSP, the Recommended Uniform Screening Panel. There are a whole cohort of disorders that are identified by newborn screening that people sort of think about in the same breath as the primary targets, but they weren't the targets of the screening, and they're secondary conditions. And I don't know how much we do when we help people know about them, except that they know. They may not be modified by newborn screening, but by golly, they know they have them. If anybody is familiar with newborn screening, probably one of the most contentious one of these secondary conditions is short-chain acyl-CoA dehydrogenase deficiency, a disorder of fatty acid oxidation, also referred to as SCAD, which is actually a pretty common disorder to pick up. And as far as we can tell, it does absolutely nothing to you. But we diagnose it, and then somebody thinks they have a disease. They think there's something wrong with them. As far as I can tell, none of the people we've ever identified with SCAD by newborn screening has ever had a problem from it. But before newborn screening, we had identified occasionally, and so is it ascertainment bias? Are we just seeing a tip of an iceberg? It's hard to know, and that remains unresolved to this day. The benefits of screening for secondary targets is unresolved. All right, this is the list of the secondary conditions. There's more on here than there are on the primary panel. So, for example, if you do a TREC assay, because you're looking for no TRECs for somebody with severe combined immunodeficiency, you're going to get people who have low levels of T cells. What do you do with those? Some of them have Down syndrome. Some of them have 22q deletion syndrome. You identify the things that are medically relevant, but that wasn't the target. And so all of these disorders are secondary targets, some of which I've probably never seen. Thank goodness. There's one, I'm trying to remember. Yeah, it's not on there. So there is one disorder that is on many people's secondary panel that no one's ever seen. They just know what the metabolite would be, and if it ever comes up, we'll diagnose it. We even have a genetic test for it. It's really something. 2,4-dienoyl-CoA reductase deficiency is what it is. I keep looking for one, but we haven't seen one since 2001. I did have one kid with metabolites, but when I finally got to do gene testing, no mutation. So I figure he probably doesn't have it. All right. So that's where we are. That's how we got to where we are. We have a recommended uniform screening panel that we had as the initial starting point for all of this to try and create justice for American babies. And what happened was that very rapidly, within probably 3 years or 4 years of the promulgation of those recommended uniform screening guidelines by the American College of Medical Genetics and the American Academy of Pediatrics, they were adopted by every state. Everybody was doing at least the core conditions. States made varying decisions about the secondary disorders for all the reasons that you can identify. Some said, well, we have to tell people if they have it. That's what we did in Minnesota, because we were doing tandem MS long before the recommended uniform screening panel. But our decision was we had to tell everybody all of the information because people deserve to know. But a lot of states did it piecemeal and bit by bit. At this point, most states do both the primary and secondary condition panels. All right. So we alluded to this advisory, what is now called, because they went through a funding hoo-ha, and for a while the secretary wasn't really giving them money, so it was discretionary, and so it was the DACADONC, and then they said, well, why don't we not worry about that and just take off the first part? So now the committee, which is still advisory to the Secretary of Health and Human Services, called the Advisory Committee on Heritable Disorders in Newborns and Children. It has a mission which is to reduce mortality and morbidity in newborns and children who have or are at risk for heritable disorders. I'll point out that this is a much broader mandate than the panel of disorders which are currently performed. People don't talk about that much, but it is a point of discussion, and it will come back as we think a little bit about how technology advances and whether this will be what we do with heritable disorders. So this is their webpage. I actually recommend, if you're interested in this at all, you go and filter through this because it tells you about the committee's business. It's very official and very public, and there's all sorts of legislatively mandated rules and time limits about how the secretary must respond to his advisory committees. So the activities of this committee presently are evaluation of new conditions for inclusion to the RUSP. That's a really important, and it takes up much of the committee's business. They evolved a process for nomination, which can be done publicly. There's a form online that any disease-interested person can send a form in and say, I want my disorder newborn screened. Anybody can do that. You know, any of you could, if you have a lovely test, could do that tomorrow. I won't tell you that it will be adopted, but anybody can nominate a condition. There's a process by which based on this initial information, an evidence review may take place. The committee actually votes on whether to send a disorder for a full evidence review. That really goes through those criteria and say, what's the treatment? What's the long-term outcome? What's the test like? What's the false positives? How are the mechanics of it? In addition, something that they've quickly figured out after they started adding tests is that they had to do a public health impact assessment. Because all of a sudden you start adding all these tests and the newborn screening programs are going, we can't do anything else. We can't even do the ones we do. So public health impact became an important part of that assessment. And then they have to vote whether to include things. And that's a very contentious process because they've just gone through several meetings where families of persons affected with these conditions, chiefly children with significant problems, say, if only you, who are listening to me and are going to vote on this, had this on the panel, my child would not be in this state. And it's heartrending to sit through those. It's extremely challenging. Yet the committee is charged with looking at the accumulation of the evidence and seeing if it meets those criteria for inclusion. It's a very hard task. I don't wish it on anybody. So the committee also has some work groups. They have a laboratory standards and procedures work group to continue to monitor complications and issues in performance of the laboratory testing. There's an education and training subgroup because it doesn't do us any good to do these things if people don't even know it. And one of the things I think newborn screening is a problem with how newborn screening was performed is that people kind of didn't want people to know what was happening because you only needed to know if it happened to you. Well, that's not good because what happens then is when people find out that somebody's done something they didn't know about, they get mighty unhappy with you because you can do public health tests without anybody knowing about it, right? But when they find out, they can get angry. And we need a lot better awareness of newborn screening in the public arena. We also have to do follow-up and treatment. As I said, newborn screening is a process, not an event. And so we need to have standards for whether we actually did what we wanted in the first place, which we honestly have done a really kind of not so good job at. We're okay with the treatment, although there are no evidence-based treatments virtually at all in newborn screening disorders. Virtually none. All right, so the committee's actually been busy. This is what they've done since 2008. They added some disorders. I'll go into these a little bit more. They added severe combined immunodeficiency. They added critical congenital cyanotic heart disease. That's a point of service test by pulse oximetry. They added, and just recently, they added these three disorders: X-linked adrenoleukodystrophy, mucopolysaccharidosis type 1, MPS 1, and Pompe disease. So they've had a bunch of disorders that weren't added. Guanidino acetate methyltransferase deficiency is a very rare disorder, but eminently treatable. 22q deletion syndrome was proposed for screening. Fabry disease, hemoglobin H, Krabbe, neonatal hyperbilirubinemia as a point of service test, Niemann-Pick. Pompe disease actually was voted on in 2008 and turned down and then came back. So there's a process by which you can re-up or reassess. And spinal muscular atrophy, that was voted down in 2008, but I would venture to bet is the next one online because of the new medications that may be efficacious in the treatment of that otherwise lethal neonatal onset disorder. So, in the reauthorization process, some of the things that we learned about newborn screening were actually highlighted in the legislation and placed as a mandate for the committee's consideration, one of which is timeliness. We used to think that, so when in the really beginning of newborn screening, they would do the test, and then and 2 weeks later, a kid with PKU would get put on treatment, or maybe 3 weeks, and it didn't make that much difference. And in fact, now that's not what happens. They're incredibly obsessed at this point, partly because of a series of news articles that took place about timeliness. The idea that if only you'd gotten my sample to the lab and had it reported out faster, my baby would be alive. And now, so they're really, it was requested that the committee address timeliness. This has gone, in my view, a little overboard because there's some things you don't have to be timely for. No one's going to die if they have PKU over the weekend. I don't need to have a call out at 5:30 on Saturday afternoon that a baby's got PKU, because if I see them on Monday, one day probably doesn't make a difference. There are other disorders where no matter what you do, it doesn't matter. They're already sick when you call out the newborn screening. So timeliness is not as much an issue in those unless you can do it instantaneously. People have even considered point of service testing for newborn screening. Not there yet. The ones are the sort of gray zone kids, the kids who might get sick at 4 or 5 days. If you can push back the timing, you may catch them before something happens. But everything is being subject to timeliness review at this point. I'm hoping that they'll right-size this eventually, because it's me that gets the call at 5:30 on Friday and Saturday afternoon. I have to figure, well, now what do I do? Do I call this parent? I can't do anything for him until Monday. Do I tell them? It's interesting. All right. They also built in this public health impact issue. It's really, really important. And thank you, Rand Paul. He added some of you may be more familiar with this, because this is where they added the expectation that the extra dried blood spot material that's left after the test, now in this particular reauthorization, I think we probably fixed it with amendments to the common rule, was to be regarded as a human subject, and you were not to use those spots for research without informed consent. I see John shaking his head. It was like a nightmare for the newborn screening community. They have to use those spots, both for laboratory performance, and I'll tell you a little bit about our sad tale here, but also for development of new tests in a research arena. You can't develop a high throughput test without lots of spots. And basically, newborn screening was going to be dead in the water if you had to get prospective informed consent for the use of every spot for anything but the test itself. So this was much angst, and many large meetings were held. All right, I'm going to drop back and just tell you a little bit about what we do here in Minnesota so you have an idea what that is about. We do newborn screening for a lot of inborn errors of metabolism. There are some specific tests plus 10 MMS. We test for all the primary and secondary targets. We do newborn hearing screening that's localized, and failed screens are referred for, they don't call them failed, they call them referred. Screens are referred because it's not a failure. People don't like to fail. And the reason that is nurses will retest a kid over and over until they don't fail. That's not what you want. You don't want that to happen, so they call it something else. And then pulse oximetry, where persons who have an abnormal pulse oximetry have an echocardiogram. In practice, that's not as relevant anymore because a lot more people have prenatal ultrasonography that identifies many disorders prenatally. But it's still a really important test. Not everybody has it. In Minnesota, these are all linked to our screening card and to the birth certificates. We have one of the programs that's most tightly associated, so we know who gets screened and who doesn't. They're state mandated. They're required. It is possible to opt out of screening, but it takes a little bit of work. So in Minnesota, when we want to add newborn screening tests, we're a microcosm of many other states, and everybody has a different way to do it. Some states have their newborn screening panels tied to whatever's on the RUSP by law. We don't. We have a newborn screening advisory committee which is actually authorized under state law and has specified membership from the community of care providers and families that are impacted by newborn screening. So there's a dietitian on the committee and a hearing professional and metabolic clinicians and laboratorians. And the committee evaluates and then recommends additions to the Commissioner of Health. We just went through that process recently and recommended addition of the 3 new newborn screening disorders that were added to the recommended uniform screening panel nationally. We didn't authorize, maybe I think there were another 4 or 5 conditions that had been proposed for legislation. And that is another, I'll get back to that. So, just people may not know of the high drama that went on in Minnesota, but I'm going to briefly describe it, which is after the Minnesota Genetic Privacy Act was passed in 2006, in a late night session, without anybody knowing it, no hearings, it just went into law, we went, whoa, Nelly, this is big, we can't even take a pedigree. People got around that. But we started asking for consent for every DNA-based test, every genetic test that we did in our hospitals here because of that law. A suit was brought up that basically says, well, the Department of Health is in violation of the Minnesota Genetic Privacy Act. And, it's a long and sordid tale, but eventually it got to the Supreme Court. And even though the court below that had decided in favor of the Department of Health, in the Supreme Court, it was decided against. And the consequence of the suits and progressive legal actions is that all of the samples that have been saved since about 1986 and all of the data associated with them were destroyed. So we have a blank slate for many Minnesota babies that we just have no information, no data on at a state level. Some of that information, the results of their tests is hopefully in their hospital chart if you can find it. But there's no central repository of that information for a broad swath of Minnesota newborn screening. The other thing that happened as a consequence of some of this is that we were not able to even use Minnesota samples to test or to do any of the lab operations. They had to request spots from another state to be able to do quality assurance for newborn screening because we couldn't use Minnesota spots. It was insane. And the Department of Health newborn screening staff spent probably 50% of their time doing discovery for these suits, bringing out documents, copying them, da-da-da-da-da-da. Interim legislation was passed in 2012 to fix this, but it was a brutal bargain, which is that specimens would be destroyed if they had negative test results at 71 days, a purely arbitrary number based on some, I don't even know where they figured it out, it's such an odd number. But it was deliberate, 71 days. If they had a positive test result, no matter what was going on, the spot was destroyed at 24 months. All tests were destroyed 24 months after the report date, which is, I think, the CLIA limit. You have to have 2 years. And so this was really crippling. That law also required education and discussion and option to consent, seek prospective and informed consent. But that's a one-by-one thing that doctors would have had to do in a hospital. It's really tough. So the Minnesota Academy, American Academy of Pediatrics initiated a legislative process. The Department of Health couldn't help because they had a solution already. But they were not averse to this happening, where the restoration bill was passed that allowed retention of spots and test results. The retention period was infinite and indefinite. You could keep them forever. New test development was regarded as program operations and not research. And there was an opt-in model for non-newborn screening related research. That's a complication that still has to be fixed and worked out and implemented more constructively. But basically we went back to where we were before all the craziness took place. And that went into force in 2014. All right, long-term follow-up. I'm going to go through this pretty quick because I want to get to the last part really fast. All right, so reminder, newborn screening, this is not to scale because all of the stuff we've been talking about pretty much, it goes from education and screening that happens before somebody's born and then short-term follow-up so people make a diagnosis. And once a diagnosis is established, at least in newborn screening programs, most people move from the newborn screening program to follow-up. Sometimes those are in the same department, sometimes they're not. But states still have a responsibility for figuring out long-term follow-up, and we've done this, realized this imperfectly. Yet it's the biggest component of somebody's life. Not that first part of life, but the rest of it. All right. Newborn screening is more than testing. This is a quote from the paper that did the recommended uniform screening panel. It's a system. It's education, screening, follow-up, diagnosis, treatment, management, and program evaluations, all of those things. All right. So the newborn screening, the regional genetics collaboratives were tasked with creative ways to improve this. And in our own region, which we used to call GLARG, and that's such a terrible euphemism, and then we added Kentucky, so we could call it Great Lakes and Great Bourbon. No, we just ended up calling ourselves Region 4 because that was our HRSA number. So in Region 4, we actually developed a long-term follow-up work group. Say, well, what can we do to improve this? And we said, well, we can treat everybody the same. We said, well, we can't do that. Nobody agreed. So we can at least figure out what we're doing. So we decided we'd start keeping track of it. We didn't have any way to do that without a data set, so we started with one disorder, MCAD deficiency, medium chain acyl-CoA dehydrogenase deficiency. It's one of the two most common inherited metabolic disorders identified by newborn screening. And we created a data set for that. We said, well, if you do that for that fatty acid oxidation disorder, you can do all the fatty acid oxidation disorders. If you have a core set of elements that you want to know about everybody, you can expand. And so by 2013, we had created data sets for all of the disorders, primary and secondary, in the recommended screening panel, and had begun collecting data through a combination of first HRSA and then NIH support. All right, we got elements that we wanted to collect from treatment protocols, literature review, a whole bunch of stuff. And what we did was we sought prospective informed consent from the identified individuals, from the people who had the disorders. You didn't have to be identified by newborn screening. It was just as helpful to have somebody who wasn't, so that we had a longer-term natural history. We would ascertain at clinic visits. It was a sample of convenience. It depended on who was saying yes, who came to clinic. But it's still more than we ever had, and we collected this in a web-based fashion so anybody could enter data from a local activity. So this kind of expanded. Mostly, if you see this, is mostly upper Midwest. The GLARG region, Great Lakes Regional Genetics Group, now called Region 4 Midwest, and some other states that were friends with us. And we created, with the association of the Newborn Screening Translational Research Network, a set of entry elements that we referred to, that are referred to nationally now as the longitudinal pediatric data resource. So there are a bazillion elements. It looks like a horrible number. You'd say, how can anybody ever do that? But they're smart forms, so you don't have to answer every question if you don't have something in that thread. We have demographics. We have special situations, collect information about pregnancy, transplant, and we have a lot of longitudinal clinical data that you collect at every visit. So this is kind of how our data acquisition grew. This only goes to 2016. We're over 2,000 cases at this point. The bars are the two to pay attention to is that not quite half, but a good chunk of our kids that we identify have either PKU or MCAD deficiency. All right, and that's just a sample of the centers that were, it's sort of like the other map. All right, this is the product. If I could show you data for each of these, but I don't have time for that today. But these are the papers that we've published so far from our data set. Our primary direction in our activity was the immediate complications and observation of newborn outcomes. So we have a paper about the whole system, about propionic acidemia, about MCAD, about VLCAD deficiency, very long chain acyl-CoA dehydrogenase deficiency, and about 3-MCC deficiency, one of those secondary targets that everybody says, oh, we shouldn't screen for that. Actually, our data suggests that a small subset of those children do have long-term impacts, and it's better that they know that they have this disorder. All right, that's our public website. It's very cute. The colors are odd, but that's our life. So I want to turn in the last few minutes to challenges in newborn screening and where we're kind of going from now. So right now, in what we do with newborn screening, we have the MSMS panels. Those are metabolic tests. We have some hormone testing, for example, for congenital adrenal hyperplasia or for congenital hypothyroidism. There are some enzyme tests. The test for galactosemia is both a metabolite and enzyme test in many places. And there's biotinidase deficiency. There's point of service testing. So the chink in the wall for all of this was cystic fibrosis. So when people decided they should add cystic fibrosis because data clearly proved that earlier diagnosis improved outcomes for those individuals, clearly, the difficulty was what test to implement because there's more than one way to go. And what ended up emerging generally in many places, though not all, is that the way to do that was to look at immunoreactive trypsinogen as a first tier, and then to do a second tier DNA test to look for mutations. And that was the crack in the wall. Now, some states said, we're not doing any DNA tests. Leave us out of that. They did IRT and then repeated the IRT. But actually, I think the ascertainment is cleaner and better and more meaningful if you do a IRT and then a follow-up DNA. And so the industry to do panels of increasing numbers of CF mutations has emerged. And at this point, that's standard practice for many states to do a DNA analysis second tier. So the second thing that happened, I can't remember, I'm going to probably mention this again because I got out of order when I got all excited, is that people got impatient with the Secretary Advisory Committee's process. It took too long to get something nominated and go through evidence review. It took 2 years, 3 years. It was forever. And meanwhile, babies were dying, was the sense of families. That's their feelings about it. And so they said, well, we have another way. We'll just go to states, because states decide anyway, and we'll go to a legislature and we'll take our baby to that legislator and we'll say, if somebody had screened for this, my baby would still be okay. And the legislator goes, oh, this is terrible. Our state will do that. Our state will do that. And so, for example, in the state of New York, they mandated screening for Krabbe disease. The genetics community was horrified because the only treatment maybe for infantile Krabbe, maybe, is bone marrow transplant. And the data is really not good for that. You may palliate it a little. The outcomes are very poorly established, yet it was mandated for screening in the state of New York, which is not a tiny state. And all of a sudden, they were responsible for screening for Krabbe, and they had to do it. And there's complications in screening for Krabbe. And the only way you can resolve that efficiently is to also DNA test, because there's a common mutation for infantile Krabbe, which was the target. So they had to develop high throughput screening as a second tier for Krabbe almost immediately. And because New York is New York, and because they can, when they also were mandated to do Pompe disease, and there is genotype-phenotype correlation to that, it does make a difference what that is when you initiate treatment, because if somebody's CRIM negative, they'll get an antibody reaction to the only treatment, which is early infusion of enzyme. They just started adding that too. So as New York goes, so goes the nation in many ways, and people said, well, maybe we should be doing more DNA. So state by state, bit by bit, people have added this. Some states do it to clarify things. So Texas doesn't make a big deal out of it. They're a two-screening state, and in between the first and the second screen, they do a lot of secondary DNA testing to figure out if somebody has variant forms of galactosemia, or they selected DNA tests. Our own state, through another challenging, difficult story, contracted with Perkin-Elmer Laboratories to perform and interpret the tests after our initial work with the Mayo Clinic. And Perkin-Elmer has chosen to quietly add second-tier DNA analysis in a sort of odd panel of DNA, very specific mutations. There are some disorders where there are common mutations, and it's highly useful to do it. MCAD deficiency, galactosemia, very high prevalence of certain mutations. But other ones, it's kind of random what ones they do. But they send us a little panel after we have a positive screen saying, well, we tested for these 5 mutations in this disorder, and maybe didn't have any of them. We go, well, thanks. But the point is that it's become a routine element for some element of DNA test to emerge. It's all second tier. It's all done after the primary test, but it's definitely there. When they added the new tests, and this is where I was getting with that, so I got ahead of myself. The SCID test it's a DNA-based test, although it's not testing for metabolite. It tests for T-cell recombination excision circles, products of T-cells as they're maturing. And if you don't have them, you don't have enough T-cells. But it's DNA-based, and it's looking for a very low thing, so it's a big PCR assay, and it's technical. In a lot of states, one of the reasons they've had trouble implementing SCID is they weren't ready to do the technology that comes with doing this particular assay. But once you know how to do that, you can do a lot of stuff. Lysosomal storage disease, I mentioned Pompe. It turns out for MPS 1 and Pompe, there are pretty interesting genotype-phenotype correlations with regard to intervention. And then XALD. This has been added. I'm not going to talk about DNA for that one because DNA is actually not that helpful for it. But DNA is really continuing to penetrate the utility as a second-tier test. So when you're doing adding a new test, you have to develop a test that uses a blood spot. You have to have methods that let you test in high throughput. You have to convince everybody has to be added. There's the national process, the state process. You might have a legislative mandate. You know my feelings on that. That's a bad idea. Do not do this. It's a bad way to do things. And then once it's added in the state, you need to have authorization to add. You need method development for that state because it's their own lab. They have to figure it out, and they have all the regulatory requirements that all of you are so familiar with. I was on a meeting yesterday with a newborn screening group of APHL, and they were having this long argument about whether you should seek CAP or CLIA certification if you're a newborn public health laboratory. And I was kind of half listening and half not, because not my bag, but it was really interesting because there are some good reasons to do one or the other. You also need provider education. We've added newborn screening tests just recently in Minnesota. As far as I know, they've done no provider education at all. Okay, so what could be? What's next? Is it time to more officially add DNA testing? And this will primarily be done by NextGen, because I think that's the only way, obviously, you're going to get high enough throughput and a broad enough spectrum to be able to do this. Most people who are talking about this, in fact, CDC had a meeting just last week about trying to bring labs up to speed in a public health setting to do targeted gene panel screening. They probably, if this goes, will be looking at already screened conditions and perhaps selected additional things. The question that many people are beginning to ask is, should this be the primary test, and should you test for more, or should it be second tier? I think this is really, really a hard question to answer, because all of you who are familiar with NextGen sequencing know it's an amazingly wonderful test. We really are very fond of it in my clinical practice. And we're grateful that we have such access to it here. But we get information we don't know what to do with. Just as you get information, you don't need to know what to tell us. So, well, that's an ugly looking mutation, but I don't know if it's bad. And that's a problem. If you had that as a primary test, what would you tell a family? And the other thing I would say is you have a DNA test. They ain't no presumptive positive, got to do a diagnosis test. That's the answer if you get 2 pathogenic mutations. You know, it's not a screen at all. Does the state want to be in the business of doing diagnostic testing that way? And who gives that information? Who's responsible for making sure families get that information? I don't think the Board of Health, the Department of Health is going to be in a position where they're going to have a cadre of genetic counselors who are responsible from the state side to make sure families have that information directly. That's not realistic. It'll fall on the clinical arena. But how do you convey that, and how do you know it's conveyed? If that's a state responsibility, because it was their test, what are we going to do? So here's my call, which is this is going to remain second-tier testing for the next wave, which I believe is coming fairly quickly, which is to do NextGen sequencing as a second-tier test. Now, you mentioned additional screening tests. There are strong proponents for doing whole exome sequencing as an early test. This is extremely controversial. In fact, NIH funded a whole series of grants to look at whole exome in neonates. The Boston group that was trying to do a prospective analysis of outcomes of babies identified with newborn screening disorders by exome, not screening disorder, but disorders screened by exome, and look at how they went. Started their project, and they have all these plans, and they have this discussion with families. They have a 7% uptake. 7% of families agree to participate. Holy buckets. That tells you that either they're really terrible at doing consent, which they might be, but even if they were even more fabulous, the uptake from that is terrifying because families don't really want that. They're not ready for this. And so it's hard for me to know what's going to happen with that. I'm not sure that doing it as a neonate is the right place. So one of the things that other people have discussed is maybe the new system needs to evolve where we do newborn screening for all these immediate impact health things. But at some point, and probably on a voluntary basis, we need to find some way of offering a more comprehensive assessment so that we could end some of the diagnostic odyssey that families experience. In that setting, you wouldn't necessarily have to promise a therapy, but you would offer new information. And that may evolve. It's very hard to know. There are a lot of people who feel strongly that exome should be part of newborn screening. In Minnesota, I remember when we were having our first fights about this, one of the legislators stood up and said, well, soon they're going to do the whole thing from the blood spot. And I went, no, that won't happen. What a silly idea. That's totally possible. You can do that today. They do it right now with blood spots. One of the things we ran into, though, one of the other groups doing, they took a different approach, which is to do sort of a targeted tier thing. And so they were using basically exome, not NextGen technology. It's not quite as comprehensive in some ways. There's technical stuff that you guys understand better than me. But when they took known cases and applied the technology they were doing, they didn't pick up the same information. It wasn't perfect ascertainment. So it's not going to be as clean as people want it to be. So when would we do this work? How would we decide who would give the information? Who's going to pay for all this? It's all going to get cheaper. It's all going to get better. We're going to get smarter how to do it, but it's still going to cost a lot. That is not a cheap test to add to newborn screening. So we got lots to do, lots to think about. Laboratorians are going to be at the heart of ensuring the precision and safety and utility of these tests. All of you in this room, that's been your responsibility professionally to make sure that the tests that you do are meaningful and that they give accurate information to families. And this is no less true in the public health arena. So we're in for an interesting ride as technology emerges and improves. Some wonderful things and some maybe scary things as well. But it's not going back. I had a slide where I had these people pushing an elephant into the barn, but I didn't bring it with me today. All right, so if we can do this, when? Can it be high throughput and timely? Does this mean our strategy for, if you do a more general sweep of the genome, what about this primary, secondary target thing? They may not be disorders we can really identify. So are those even the criteria we still want to use? Is that old-fashioned? Some people argue it is, that knowledge is just as important as treatment. It's a public health measure, but should you mandate it? Should you require that people undergo it? Who shares the information? And should a screen be a diagnostic test? Those are hard things to answer in the context of using genetic testing in a public health setting. All right. I'm going to skip that. So newborn screening is at the intersection. Newborn screening is a public health responsibility, and data about newborn screening is critical. It's critical to surveillance of lab performance. It's to the assessment about the newborn screening process, the lab stuff, the diagnosis, the follow-up. You have to know what service needs you have, and you have to do research to improve testing management and new treatments. So it's a process, not an event. You have to keep improving the new tests. That's what we've just spent time talking about. How do you do it better? Are we doing the best we can? Are there new tests? Do we have better outcomes after tests? Do we choose the right tests? Lots to learn, lots to do, and we're trying to do a balance. Public health, individual responses, because it's a public health thing, but you're talking about a baby. So it takes a village. All of these people are critical to how it's happened. Our clinical work is done between our division and the division of gastroenterology. I am entirely and utterly indebted to my biochemical genetics colleagues here and also at Mayo. The newborn screening program is great at our interface with clinicians, and their long-term follow-up program is instrumental in how we do things with our babies. So that's my funding for the inborn error stuff, and with that I'll stop.
We have time for a couple of questions people have.
Two questions. One is that as the interim solution to NextGen, people talk about using chips, and the other question is any interest in infectious disease in newborn screening?
So I'm pretty sure that rather than standard NextGen, they will do chips first. That's a lot more controllable, and you can put on what you want. The trick is, are you going to put the right things on the chip? But that's really, at this point, how almost all labs do, for example, the DNA testing for CF. It's all on chips. Infectious disease, harder question, because there's this what we call iceberg effect in a lot of these. One of the things we did when we got disorders, we found out that things that we thought were really bad diseases are only a tiny fraction of them, and that most of the people who have these diseases have a much milder phenotype, or none. What the iceberg effect. And that's even more true, if you will, in many infectious diseases. It's hard to know. There was quite a rage for doing toxoplasmosis testing for a while, and ended up feeling and evolving into something where better education was the way to do that. CMV is the next sort of disorder that's emerged for that. Only about 10% of kids who are detected by newborn screening actually have hearing loss, which is the reason you're doing it. So it's hard to know if that's the right way to go. But it will continue to be an element.
Two quick questions. Is there anything that other states have experienced along the data privacy problems that we've had here in Minnesota? And is the opt-out similar to the vaccine arena in any way?
So the answer is yes. We have a privacy, I'm going to be editorial, absolutist, based in Minnesota, that has had a tremendous influence in other states and nationally. And so Texas went through a lawsuit that was just about like ours. They settled before they finished, but their settle was to burn not 1986 forward, but 4 million spots. They burned it too. And so they settled to cause that. And this is a constant battle. It pops up everywhere. There's a suit in Indiana right now. And each one is on a different basis, but they're all from the same place. It's all about privacy. So the government has my baby's DNA. That's the key. In terms, that second question, remind me?
Was the opt-out?
Okay. So one of the things I think that probably is emerging, this is done in Michigan, for example, is a strategy by which families actively participate in that research process. And they try to create a process so that the Michigan has a Michigan BioTrust, what they call. They save the spots of people who say, you can keep my spot actively. That's good in some ways and bad in other. In one way, you know that somebody said, yes, you can have my spot. In the bad way is if you have a community that's very distrustful, you will have no spots from that community, so you don't have a true representation of the community. This remains an area of controversy.
So Sue, if you opted that your spot could be kept,
Mm-hmm.
and you had a late onset disease in the family, could you access your spot
As an individual?
as an individual?
Yes. Yes.
To get
Yes, you
back
could.
to do testing of a...
And in fact, one of the most salient arguments that we had, it was not from us doctors or from the Department of Health when we changed the rules. It was from a mom who had a child die of SIDS, and then she had another child who was reaching the same age. And they'd always said, well, we can go back and check that a little bit later when your kid's a little bit older, if we can do that. And so she went back cheerfully at a certain age to do that and found out that the child's spot had been distorted 2 weeks before. She was infuriated. She wanted access to that spot. It was hers to have in many ways, yet the state of Minnesota had burned it to protect the rights of people who said they didn't want someone to access their spot. So that was actually a very telling argument and carried great sway. Yes, you can access those. The other thing that those spots have been used for quite generally is for things like they're snapshot in the environment at the moment the kid's born. They've been used for everything from cancer detection to lead screening in an area by pulling spots, and you can actually do profiles from the spots. I don't have to know who they are. But you can get some snapshots of public health and disease from the spots, not just what we use them for. So that maintaining the spots is actually quite important on a general basis as well as an individual one.
I want to thank you for...